You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 22nd, 2025. This week, we're talking conduction system pacing versus regular pacing, withdrawing heart failure meds when atrial fibrillation is corrected, and patient selection in left atrial appendage occlusion, and then a few announcements. Jack has published the CS PACE trial from a group in Melbourne, Australia, comparing conduction system pacing to RV pacing for patients who have a pacing indication. As I have said many times in this podcast, I believe strongly in conduction system pacing. I am in my 9th year of doing it, starting initially with his bundle pacing and now using predominantly left bundle pacing. Now, by placing a pacing lead in a conduction system, either in the His or the left bundle branch block, you activate the heart naturally, without the dyssynchrony inherent in RV pacing. Now, why is this? Now, let me just say something basic here. A standard pacing lead placed in the RV muscle activates that muscle around the lead. The wave of depolarization spreads through the RV, then to the LV. This results in a dysynchronous contraction because the RV contracts first, then the LV. And in 10, 20, or 30% of the time, this dyssynchrony can cause cardiomyopathy. And make no mistake, dysynchronous contraction from RV leads is better than no contraction. So pacing has been transformative technology. But the idea with CS pacing is activating the His bundle or the left bundle branch block. You allow simultaneous activation and contraction of the two ventricles. Now, the problem, of course, is that conduction system pacing is harder than RV pacing. It requires skill. You have to practice. You have to know how to evaluate electrograms. CS pacing can cause perforation of the septum, and it may require more lead revisions. On His bundle pacing, when we first started, was marred by high pacing thresholds, and of course that leads to less battery longevity and more generator changes, and that is a negative. Now, skeptics of conduction system pacing stand on solid ground. They are correct to want evidence of benefit of this new technique, because beautifully narrow paced QRS complexes is not enough. The beauty of an ECG when you do conduction system pacing is remarkable, but that is not evidence. Now, EP has been late to get data on CS pacing, of course, because industry is not interested in funding trials. The reason for that, of course, is that A, it would reduce the need for more costly CRT devices, and B, it may be able to do with 2 leads, an atrial and ventricular left bundle lead, what can be done with 3 leads, an atrial, RV, and CS lead. The CS PACE study, therefore, is a welcome addition. In CS PACE, 100 patients were assigned to CS pacing and 100 patients to RV patients. Investigators encouraged implanters to use an RV septal lead position over the RV apex. The primary outcome was a composite of pacing-induced cardiomyopathy, an upgrade to a biventricular CRT, a heart failure hospitalization, and all-cause mortality. Pacing-induced cardiomyopathy was defined as a left ventricular ejection fraction reduction of greater than 10% and an EF less than 50%. Patients were excluded if they had a CRT indication, such as an EF of less than 35%, a QRS width of greater than 120 milliseconds. They also excluded patients with end-stage renal disease, dementia, and limited life expectancy. Now, the first result of this trial was that conduction system pacing was successful in 88% of patients, which is pretty good, but it was 99% for RV pacing. Conduction system pacing required longer procedures, more fluoroscopy time, and there were more lead revisions, 8 versus 1 in the CS pacing versus RV pacing group. After 2 years of follow-up, conduction system pacing was associated with the lower composite endpoint, 7.2 versus 20.7 events per 100 person years. That hazard ratio was really low at 0.35. 95% confidence intervals were 0.19 to 0.64, and obviously a highly significant p-value. Now, the composite primary endpoint was driven primarily by lower pacing-induced cardiomyopathy and the need for CRT upgrade. There were no differences in hospitalizations for heart failure or all-cause mortality, and when they looked at left ventricular ejection fraction median or mean, there were no significant differences. The authors concluded that in patients with AV block, conduction system pacing resulted in a lower incidence of pacing-inducing cardiomyopathy and the need for biventricular CRT upgrade at the expense of a higher requirement for lead revision compared with RV pacing. There were no differences in heart failure hospitalizations or mortality, and they said that this RCT supports the broadening of the indication of conduction system pacing as an upfront pacing technique for pacemaker implantation in patients with AV block. I'm not so sure about that. My comments. This is exactly what we should be doing with new procedures. We have to laud these investigators' effort in doing this trial. We should be randomizing versus standard pacing. Hundreds of thousands of pacemakers are placed worldwide, and if we randomized only a fraction of these pacers, we would have answers about CS pacing versus RV pacing. And I have to say that retrospective, look-back observational studies trying to adjust for baseline differences is not the way to answer the question of CS pacing versus standard pacing, because obviously different kinds of patients get different kinds of devices. Probably healthier patients will have conduction system pacing, and sicker patients will get regular pacing. But at minimum, this trial shows that CS pacing is achievable though harder than standard pacing. There was more radiation required, more lead revisions, and that is not nothing. Hard outcomes, like heart failure hospitalizations or death, were not statistically different, though 7 versus 1 heart failure hospitalizations in the RV versus CSP group is certainly a strong trend favoring CS pacing. But the reduction of pacing-induced cardiomyopathy, I think, is an important endpoint, especially when doing pacing in younger patients. Applied to a larger scale, a 70% reduction in pacing-induced cardiomyopathy is going to translate to a large benefit. Yet we should not overinterpret this study. This was a very small study with very small numbers of events. The main driver of the positive outcome was a left ventricular ejection fraction measure, which is always fraught with imprecision. As I have said numerous times, left ventricular ejection fraction differences are a bit like judges who give harsher sentences before versus after lunch. Left ventricular ejection fractions vary a lot. And of course, the follow-up was too short for this study. People with pacemakers live decades after they have a pacer. And a 2-year window is not nothing, but longer-term lead performance is important. The 8 versus 1 lead revision rate is a huge headwind for this technique, because if you apply such a ratio to 100,000 pacing cases, that is a lot of harm we're doing, as lead revisions have a higher rate of device infection than de novo implants. Another factor in this trial is that patients with an EF greater than 35% and less than 50% were included. I cannot tell how many of these patients there were, but these are patients in whom the Block HF trial found benefit from CRT over standard pacing, so randomizing these patients to RV pacing alone may have created a bias in favor of conduction system pacing. The CS pacing trial, I believe, is very preliminary data. It does not satisfy the medically conservative clinicians who want evidence for net benefit of this new approach to pacing. Let's not forget the recently published BioPace trial of CRT versus RV pacing in patients who have a pacing indication but a narrow QRS and a normal LVEF. Like these patients, the BioPace trial did not find a clinical benefit to CRT over standard pacing. Now, arguably, conduction system pacing is probably less technical and less complex than doing BiV pacing, but still, BioPace found that less was more when it comes to standard pacing. Conduction system pacing does have enough signal of benefit, I think, to support funding of a very large trial of heart outcomes, which will have to come from government. I see this as a huge unmet need in the evidentiary landscape of cardiac pacing. I believe in CS pacing will win out in the proper trial. And if I were to have a pacemaker, I would want a skilled electrophysiologist to place a left bundle area lead. But my beliefs are not evidence, and so the skeptics are correct, and I don't think we should overinterpret this trial to be a practice-changing trial. It's a good trial, and it's preliminary evidence that's positive, but we need more evidence. All right, speaking of another preliminary trial, the Withdraw AF RCT was published. And yet another group from Melbourne, Australia, has published this RCT, which asks such an important question. Can guideline-directed medical therapy be stopped in patients who had heart failure with reduced ejection fraction from atrial fibrillation after correcting the AFib? And this scenario comes up often, right? A patient who has not had heart failure before then develops atrial fibrillation with rapid conduction. This causes shortness of air, BNP elevations, pulmonary edema, clinical heart failure. The echo done during rapidly conducting AF invariably shows left ventricular dysfunction, and the patient is diagnosed with HFrEF. Now, too many times, I believe, the heart failure docs don't ask electrophysiologists to help. And these patients get put on guideline-directed medical therapy, and the AFib treatment is delayed. My colleague and key opinion leader, Roderick Tung, is out there trying to promote the concept of sinus rhythm therapy for heart failure. The idea is if you phone a friend in EP, we can help correct the AFib. And if successful, the EF may normalize, and voila, the patient is no longer in heart failure. Then the question becomes, can we stop the guideline-directed medical therapy, the beta blocker, ACE, MRA, SGLT2? Now, the TREAD-HF trial, published in Lancet, now linked to it, found that withdrawal of guideline-directed medical therapy in patients who had non-ischemic cardiomyopathy but recovered EF was actually harmful. This and other studies have led guidelines to recommend indefinite GDMT regardless of the cause of heart failure. But clearly, AFib cardiomyopathy seems different. Resolution of AFib and maintenance of sinus rhythm eliminates the cause of the LV dysfunction. At least this is the theory. The Withdraw AF study had a neat design. It was only 60 patients who had had a recovered AF and were maintaining sinus rhythm, and they were randomized to two arms. The one arm was early withdrawal of meds. They called that Group A. And then patients crossed over with delayed withdrawal of meds, Group B. Go look at the design picture in the paper. It's actually really good picture. It's hard to describe with words, but basically, a Group A had their medicines withdrawn. They had a CMR at the end. Group B continued their meds. They had a CMR done, and then the group crossed over. Group A had reintroduction of medical therapy, and then after 6 months had another CMR. Group B then withdrew their meds and had a CMR after 6 months. The crossover design was selected to ensure 1, similar follow-up between groups, 2, each subject served as their own control to mitigate confounding and to do other secondary analysis, and 3, to examine whether the timing of treatment withdrawal influenced the primary outcomes. Now, CMR was done a lot, right? Done at crucial periods. At the initiation of trial, everybody had CMR. After 6 months of withdrawal, then again, after restarting meds, in the delayed arm, CMR was done at the study onset, then after being on GDMT for the first 6 months, and then after being off the second 6 months. A lot of CMR was done. And here's a note on the patients. The trialists were careful to make sure that these patients did not have evidence of other causes of cardiomyopathy, which is important clinically. They looked at scar burden on the screening CMR, and they had to have documented sinus rhythm. AF burden was assessed with twice daily cardia tracings in 90% of patients. Now, you could argue that an ILR would have been better, but 2 daily ECGs are not bad. 97% of the patients had sinus rhythm maintained via an AF ablation. Now, supervised withdrawal comprised of a stepwise reduction in heart failure pharmacotherapy every 2 weeks to a maximum of 12 weeks. And this was adopted from the TREAD-HF protocol. However, unlike the original TREAD-HF medication weaning protocol, in this study, beta blockers were weaned first to allow earlier detection of atrial arrhythmias in this AFib population. The beta blockers might otherwise suppress early signs of relapse due to early arrhythmia recurrence. The medication withdrawal was extremely careful, and it was stepwise, and there was lots of surveillance, and this is important in external validity. The primary endpoint was maintenance of a CMR greater than 50% at 6 months, assessed by blinded endpoint evaluation and compared between randomized groups, Group A versus Group B. And the authors had many secondary outcomes. Okay, the results. During the first 6 months, 27 of the 30 patients in Group A did indeed maintain an ejection fraction greater than 50%. That's compared with 100% in Group B. That was not statistically different. CMR-derived left ventricular ejection fractions were nearly identical. At 6 months, participants crossed over to the alternative treatment arm, and following medication withdrawal in Group B during the second 6 month period, 28 of the 30 participants maintained an LVEF greater than 50% following the medication withdrawal. Now, there was an important caveat in 5 patients. It's only 5 patients, but I think there's a lot of information here. They found a reduction in LVEF to below 50% in 5 participants following short-term medication withdrawal. 3 from Group A during the initial randomized phase, and 2 from Group B during the crossover withdrawal phase, and this was detected on the CMR at 6 months post-medication withdrawal. The median reduction of LV ejection fraction wasn't a lot, it was about 7%. However, this was not seen on the transthoracic echo. The LVEF reduction was accompanied by an increase in LV end diastolic volume and an elevated NT-proBNP levels, but it also occurred without clinical heart failure or major adverse cardiac events. Now, one of these 5 patients had had an AF recurrence, and that led to antiarrhythmic drug therapy. All 5 of the patients had normalization of the EF with restarting guideline-directed medical therapy. And on serial CMR imaging, 4 of the 5 individuals who relapsed had developed new left ventricular LGE, and 2 additional individuals who did not have a decline in LVEF had developed new LV-LGE at 12-month follow-up. Now, AF recurrence was present. AF recurred in 26 of the 60 participants. That's overall 43% with similarly low AF burden on and off heart failure therapy. The rates of cardioversion was 6, repeat ablation 7, and they were similarly low between groups and across treatment periods with no associated LVEF decline. For secondary outcomes, there were no differences observed in NT-proBNP, cardiac imaging, New York Heart Association class, symptoms, and quality of life scores. And the authors did allow some extended follow-up, and at 12 months, 55 of 60 participants had maintained an EF greater than 50% off heart failure therapy. A handful had restarted medicines for other kinds of problems like hypertension. And during an additional 12 months observational follow-up, all 50 participants remained clinically stable with sustained LVEF normalization and no adverse clinical sequelae. All right, my comments that this is really, really nice work. It's a good example of a small sample that provides important data. The crossover design was also informative. Coming off guideline-directed medical therapy is a huge deal for patients, not just in cost, but in the burden of being a patient and taking these many pills forever. I take from this study the following. If you are extremely careful, and I mean really, really careful, patients with clear AF-related cardiomyopathy can be taken off guideline-directed medical therapy. Careful means being sure that they don't have AF recurrence. Careful means going slowly, and that you vigorously watch LV function. Unlike in TREAD-HF, where 44% of the patients taken off heart failure meds relapse, this study, it was only 8%. And surely this reflects the fact that AFib cardiomyopathy is a different sort of entity than old-school non-ischemic cardiomyopathy. And it also suggests that AFib cardiomyopathy is reversible with sinus rhythm therapy. But I also take from this data that there is a small number of patients who may have enough underlying cardiomyopathy that they see reductions in EF with withdrawal of medicines and should be put back on GDMT. 5 patients out of 60 is not a small number. I think this is a nice study, but we must be extremely careful translating this to the clinic. These were highly selected patients who had documented reversal of AFib, and great care was taken to exclude other causes of heart failure. Plus, after the AFib was reversed, there were no other reasons to take meds, such as hypertension or diabetes. And CMRs in everyone, multiple CMRs, is perhaps something that is difficult to achieve in real-world practice. We must remember that many patients have persistent AFib because of cardiomyopathy. Not all patients with AFib and cardiomyopathy have an AFib-related cardiomyopathy. Some have cardiomyopathy that then causes the AFib. So think of it as the causal arrow going the other way. These patients should not have meds withdrawn. They were excluded from this study, in fact. And 5 of 60 patients in the study were thought to have AFib cardiomyopathy, but actually had cardiomyopathy exposed by medication withdrawal. We must be vigilant about these people. That said, I do believe that it is worth considering withdrawal of GDMT in these patients. If you have fixed the cause of heart failure and there is no other pathology, you have done a great service to the patient by removing the need to take 4 classes of medicines forever. The other take-home from this trial, perhaps the most important one, is that patients with AFib and heart failure benefit from a collaboration between heart failure and EP specialties. Rod Tung is correct. Sinus rhythm is indeed a beneficial heart failure therapy. All right, another topic is patient selection in left atrial appendage occlusion. The Journal of the American Heart Association has published a retrospective review of long-term outcomes after appendage occlusion. This is from the NCDR registry. I mention this paper because there is one data point that is very reliable, and I think it's very important. The authors looked at all patients getting a Watchman from 2016 to 2019. So this is already old data, but that's going to be important. They then matched outcomes using linkage to other databases. The sample was nearly 35,000 patients. The mean age was 77 years, 42% female, and these were high-risk patients with a mean CHA2DS2-VASc score of 4.7. And there's one data point I want to discuss, and that is that death occurred in 11% at 1 year and 44% at 5 years. These high death rates way outpaced the stroke rates, which were only 1.7% and 5.7% at 5 years. Now, this observation shows how badly we are choosing patients for left atrial appendage occlusion. The point of this procedure is to prevent stroke with less bleeding over years and decades, not months or 1 year. In this study, 1 in 10 patients, those who died in a year, garnered no benefit from this device. The only people who benefited, patients who died within a year, are the hospital and the doctor putting it in, and the company. Nearly half of the patients in this series having this procedure were dead at 5 years. I think this highlights the crucial concept of competing causes of bad outcomes. We don't seem to do a good job with this in our practice. Death rates in this cohort are nearly 10 times the rate of stroke. And this was from 6 years ago. Multiple analyses that I could cite have shown that we continue to implant appendage occlusion devices in older patients with comorbidities. I know many of you disagree with me about this procedure. You think there are patients that benefit from it. Now, I can't find evidence for this, but let's say you're correct and I'm wrong, and there are a fraction of patients who might benefit. Surely we can all agree that if your patient is sick enough to die within a year or 2 or 3, they cannot benefit from left atrial appendage occlusion because it is a long-term, not short-term strategy. During my first ever Watchman debate, I've lost them all, but this was the first one. Professor Horst Sievert said in the question and answer session that patients with frailty, older age, and comorbid conditions are the least likely to benefit. He was right then, and he's right now. And this makes perfect sense because both stroke and bleeding are relatively rare causes of death. I mean, go ahead and look up the population attributable risk of stroke and bleeding relating to death. Stroke causes about 1 in 10 deaths, and bleeding is only around 1 to 3%. If your patient has 15, 20, 30 different threatening medical conditions like immobility or falls or poor nutrition or frailty, then you almost certainly harm them with left atrial appendage occlusion. All right, next week is a big week. Next week is Madrid, ESC. I will go as a medical journalist, and I'm going to plan to cover the major studies. And there are going to be some great studies to discuss. My preview column will be out next week. I know that there will be some good discussions coming from ESC. Also, last week I discussed the hypertension guidelines, but this week I've penned some dislikes and likes, and I've put it in written form, and it's up on the website. Go take a look at that. Until next week, in Madrid, Spain, this is John Mandrola from the Heart.org Medscape Cardiology. As always, if you like this podcast, please take the time, write us a review. If you don't agree with something I said, send me a note. And I'll see you all next week.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.